In this presentation, we'll cover the topic of optimizing IO biomarker testing workflows. I'm Dr. Rex Hung from Harvard Medical School and Massachusetts General Hospital, Department of Pathology. In this presentation, I'll first discuss options to evaluate PD-L1 immunohistochemistry and strategies to optimize PD-L1 staining protocol. Next, I'll discuss caveats in evaluating MSI and strategies to optimize MSI testing workflow. Finally, I will discuss factors that can confound TMB determination and methods that can lead to more accurate determination of tumor mutational burden. First, PD-L1. In this global survey by IASLC on PD-L1 immunohistochemistry from over 340 pathologists from 64 countries, PD-L1 clones most commonly used include 22C3, followed by SP263, SP142, 28.8, and U1L3N. 76% of participants developed at least one laboratory-developed test. Quality assurance was noted in 82% of participants. Standardized reporting was noted in 86% of participants. And half of the participants reported turnaround time for PD-L1 immunohistochemistry of no more than 2 days. Currently, there are multiple PD-L1 antibody clones commercially available, some of them shown here, and they differ in their company sources, isotype, host species, and intracellular versus extracellular binding sites. Given the multiple PD-L1 assays and clones available, one may wonder how concordant they are. A study led by the NCCN showed analytic interchangeability of 22C3, 28-8, and U1L3N. The Blueprint 2 study showed analytic interchangeability of 22C3, 28-8, and the SP263 assays, and that these assays are practically equivalent. Both studies, however, noted lower sensitivity of the SP142 assays for PD-L1 TPS determination in non-small cell lung carcinoma. With regards to PD-L1 immunohistochemistry scoring, higher concordance was noted in scoring tumoral PD-L1 expression as compared to immune or stromal PD-L1 expression, as shown in these two studies here. As long as specimen fixation and adequacy do not present technical issues, there's no significant difference in the evaluation of PD-L1 tumor proportion score TPS using cytologic specimens as compared to surgical samples, as shown in this summary of multiple comparison studies. In cytologic specimens, while tumor proportion score evaluation can be reliable, evaluating immune PD-L1 expression is generally not reliable. To optimize PD-L1 immunohistochemistry, here are some general considerations, including specimen age and condition, modality, sample size, biopsy versus resection, and sample site, primary versus metastasis. There's a minimum criterion on specimen adequacy, with at least 50 to 100 viable tumor cells on the slide, depending on the assay. If multiple sites are available for a given tumor, the recommendation is to test the one with the best technical quality. Here's a list of optimal pre-analytic conditions for PD-L1 immunohistochemistry that can be applied to biopsies, resections, and cell blocks. They are good for general practice. Use conditions appropriate for optimal formalin fixation. Testing on unstained slides stored no more than 2 months at room temperature, or from unstained slides freshly cut from paraffin blocks that were stored no more than 3 years will be optimal. For PD-L1 immunohistochemistry, one may consider to use companion or complementary diagnostics and can refer to the manufacturer protocols for instructions. For assay validation, one can use known cell line positive controls or tissue controls such as tonsil. Laboratories may choose to validate PD-L1 immunohistochemistry as a laboratory developed test, LDT, due to lack of assay-specified autostainer platforms such as Darko Link 48 for 22C3 or Ventana Ultra for SP263. Here are some representative images on using standardized cell line controls in the top row or tonsil tissue control in the bottom row to validate PD-L1 immunohistochemistry. Use of reference specimens and/or cell lines with defined expression levels covering the entire expected range of PD-L1 is preferred. Using tonsil or placenta controls alone may be insensitive to assess changes in the protocol setup. Shown here are some principles from CAP Lab Quality Center that one can apply when validating PD-L1 or other predictive biomarkers. For initial validation, achieve at least 90% concordance between the new test and the comparator test or standard. Test a minimum of 20 positive and 20 negative cases. The validation cases should be processed in the same way as the clinical cases. And finally, it's important to document all validations and verifications in compliance with regulatory requirements. After test validation, continual quality monitoring and participation in the external quality assessment, such as PDL1 proficiency testing offered by CAP, will also be critical to ensure test quality. Shown here is the most recent guidelines on PDL1 testing in the management of patients with non-small cell lung carcinoma. Use validated PDL1 immunohistochemistry assay in conjunction with molecular testing to optimize selection for ICI treatment. Ensure appropriate validation performed on all specimen types and fixatives. When feasible, use clinically validated assays as intended. Pathologists who choose to use LDT for PD-L1 expression should validate according to the requirements of their accreditation bodies. Finally, report PD-L1 immunohistochemistry results using a percentage expression score. Now we're going to discuss MSI. In MSI testing, for the three methods, MMR immunohistochemistry, PCR-based method, and NGS-based testing, there can be caveats, including technical factors and interpretation. Use of more than one method is recommended when encountering aberrant or equivocal results in order to ascertain the correct MSI status. In MMR immunohistochemistry, a common pitfall is the presence of heterogeneous, reduced, or complete absence of tissue staining due to poor fixation, as shown in these images here. The solutions to this problem include proper tissue fixation and ensure there's strong staining in the internal control, such as the stroma, when interpreting tumoral expression. Another common pitfall is seeing unusual staining patterns, such as cytoplasmic only, dot-like, or nucleolar pattern. To mitigate this problem, in some cases, one can use a different antibody clone in some settings. In other cases, testing pretreatment biopsies rather than neoadjuvant samples can resolve this problem. Subclonal loss can also present interpretation challenge in MMR immunohistochemistry. Some cases with subclonal loss of MMR IHC have been found to harbor germline defects. For MMR immunohistochemistry testing, here's a summary of common pitfalls and strategies for avoidance. These problems can generally be resolved either with repeat testing with better fixed or pretreatment tissue samples, optimized pre-analytic and analytic conditions, and/or orthogonal testing such as MSI by PCR. For MSI testing, here are some points from the good practice statements. In the event of discordant results, pathologists should interpret any evidence of MMR deficiency by IHC or MSI by NGS or PCR as a positive result for patients to be eligible for ICI therapy. Discordant results should be reviewed to ensure that the discordance is not due to an interpretive error. In the event of an indeterminate result in any method, pathologists should perform an alternative technique or repeat on a different tumor block. Laboratories should have a robust peer review process for indeterminate cases. In the event of a clonal loss by MMR-IHC, pathologists should perform MSI by PCR specifically in a dissected area of tumor that has IHC loss of MMR protein if the patient is being considered for ICI therapy. In the last segment, we'll discuss TMB. Tumor mutational burden (TMB) evaluation can be complicated as there are multiple assays, including whole exome sequencing or panel-based next-generation sequencing. Some assays only sequence tumor with no matched normal tissue. The assays also differ in how different types of mutations, such as driver mutations or indel, are included or excluded in their TMB determination. Although whole exome sequencing represents the gold standard, tumor mutational burden determination can be achieved using targeted next-generation sequencing. One commercial NGS assay reports its TMB of 10 mutation per megabase, corresponded to a mutational burden of 199 missense mutations by whole exome sequencing, providing a calibration of its NGS data with whole exome sequencing data. In TMB determination, there are multiple technical and clinical challenges in harmonization and implementation. Technical challenges include different informatics pipelines, lack of germline control in some panels, and the presence of subclonal mutations and artifacts. Clinical challenges include the relatively longer turnaround time as compared to other biomarkers, and our evolving understanding on how its predictive value may depend on the treatment type and different TMB cutoffs. Specifically on the technical factors affecting TMB determination, technical variability, insufficient tumor purity, inexact filtering of germline variants, stochastic variability in smaller panel, and biological intratumoral heterogeneity can all affect the accuracy of the TMB determination. There have been recent harmonization and standardization efforts to address these issues. TMB determination varies with tumor purity. TMB determination is accurate for tumor purity of at least 60%. TMB can be underestimated when tumor purity is less than 40%, which can lead to misclassification of patients that may benefit from ICI. TMB determination also varies with germline filtering in NGS panels that sequence tumor only with no matched normal tissue controls. As shown in this study, inexact germline filtering can lead to the inflation of the TMB. For consistent assessment of TMB, multiple recommendations have been proposed, covering pre-analytic factors, sequencing parameters, bioinformatics, and comparisons of results. This includes standardization of sample processing protocols, larger genome coverage of at least 1 megabase, alignment of panel-derived measurements to whole exome sequencing-derived standards, and development of templates and consistent reporting as well as calibration across multiple sites. To conclude, on the topic of optimizing IO biomarker testing workflows, PD-L1 testing can be challenging due to technical challenges and inter-observer variability, which can be addressed via optimization. Most PD-L1 assays are equivalent, except the SP142 assay, which is less sensitive. Histologic and cytologic specimens can be equivalent for testing, as long as tissue adequacy and fixation are not the issues. TPS assessment among pathologists show high concordance. For MSI testing, use of more than one method is recommended when encountering aberrant or equivocal results. For TMB evaluation, it can be more accurate when using samples of higher tumor purity, sequencing panels with larger genome coverage, and standardization.